not going to talk about my PhD at all today. We thought we would like to introduce a little bit about rural health and where we're coming from. Great. As a bit of a background and context for what we're going to talk about. So the rural health is situated, so this is the University of KwaZulu-Natal, there's the College of Health Sciences, we've got 4 schools. We are situated in the School of Nursing and Public Health. Okay, and in rural health there's both a discipline or Department of Rural Health that is headed by Mosa, who's just been introduced, and that's really the academic focus of rural health. And then there's the Centre for Rural Health, of which I'm the director, and it's a research centre, and we're really focusing on trans-disciplinary research. And we're really kind of trying to find the synergy and utility of both of those structures. So the staff of the discipline and the staff of the centre are really one entity in many ways. The focus areas of rural health that the centre or that the discipline is focusing on is the rural teaching platform, so really trying to develop decentralised teaching, health systems improvement and quality improvement work. There's an increased focus on health and livelihoods. We're busy setting up quite a large initiative around that. And then there's also a focus on health equity and access. And activities are kind of fairly typical for academics, for academia. It's teaching and learning, trans-disciplinary research. We are kind of really using a platform of teaching, of service, of engagement and advocacy for our research and for our teaching and learning. And then we're increasingly branching out into collaborations and enabling environment, and that's partly of how this visit to Duke has come about. And we're really kind of focusing on implementation research and knowledge translation in context. So that's really just a quick taste of where we are. The topic for today is really looking at the HIV services in rural areas and kind of what we can learn from that. And for that, I'd like to give a little bit of the context of that. So we'll start off in the beginning of the ARV rollout in South Africa, and how that kind of came about in rural areas. So we had, as you probably all know, kind of South Africa or Sub-Saharan Africa has had this really, or still it's having this really massive epidemic or pandemic. And the political landscape at the time was very difficult. There was still deep in the AIDS denialism with Manto and Shabalala Msimang and Mbeki. And there was also very kind of strong activism around AIDS, especially the TAC. The organizational landscape of the Department of the Ministry of Health, was then and still is very much a system in crisis and really struggling to deliver. And in that context, the attitudes towards rural is that anything that happens in rural that is successful is a miracle. There's also this assumption that everything relies on personality. So if there's a good guy in this hospital, then things work, otherwise it doesn't. There's also this assumption, so all of these question marks is kind of the attitudes that we have, is that rural people are less demanding. They take anything that they get. There's also people that work in rural areas are generally the mad, the sad, and the bad. And there's also a kind of story about rural, that rural always will remain poor. So you can't actually succeed. The moment you are successful, are you still rural? Like rural equals deprivation. So do you stop rural when you're not deprived anymore? You stop being rural. But at the same time, the rural systems themselves, the healthcare system in rural areas, it's much more vulnerable because there's smaller number of people. So if you're kind of a team of 5 clinicians working in a hospital and one person leaves, 20% of the workforce is just walked out the door. So you really become quite vulnerable in that sense. But at the same time, the flip side is that you're also more resistant. Like you can cope with 20% of your workforce walking out the door, which a lot of large systems don't manage to cope with. And I think a key thing is that your parameters are much better defined. Your populations are often much better defined as in urban areas. The kind of linkages of different levels of care are often much better defined. So I think that's just a part of the context. the policy context is quite important. So the motivation, I mean, the policy development for this ARV rollout was very complicated because of the larger political context that I already mentioned. But also it was recognized that the medicines were very complicated. A lot of people had no experience with ARVs at all. The systems were very complicated in terms of the drug provisioning, the lab requirements, and then also the internal politics, or the politics with a small p, the kind of organizational politics, the professional politics. So only specialists really know how to do things, and kind of the doctors and nurses in the periphery, being mad, sad, and bad, probably shouldn't be allowed to even touch these things. And then also the whole rollout has been and still is very resource intense. So therefore, there was a process of sites needing to be accredited in order to provide the ARVs. And that was quite an intense process, and that was kind of delayed a lot of people getting access. There was also, let's first do the cities, where in kind of their large hospitals, so we can reach many people. And that's also where the specialists were, and they kind of reaffirmed the sort of only the specialists can do this kind of approach. But then kind of we should roll out to rural areas. It was a completely hospital-based system, so kind of all the patients needed to go to hospital to access the care. And kind of because of this needing to set up a new system, it was nearly like a parallel healthcare system. It was really a standalone ARV service. So people were hired specifically to work in the ARV service as opposed to the rest of the service. So it was like this silo. So out of that, when this policy was starting to be implemented, which were the most successful programs? So the policy, there was a previous policy that went up to 2006, a new policy, the National Strategic Plan was from 2006 to 2011, and this is more or less the time that I'm placing this. So at the beginning of 2007, the most successful programs were where the red circles are, and as you notice, if you know a little bit about the geography, Cape Town is down here. There was a very successful program from MSF in Khayelitsha, and then in Gauteng at the top is where Joburg is, and that is the other urban area. But the rest of all of the successful ARV programs were not in urban areas. So kind of all sites, I'll come to that little asterisk a little bit later, all sites reaching the population-based targets of the 2011 targets, so basically where we should get in by 2011 in this plan, were the sites that reached these targets in 2007 were all rural. And maybe to go back, the ones that cluster up in the right-hand corner in KwaZulu-Natal and far northern KwaZulu-Natal, all of those were reaching it. The one next to it here, that's Emmaus Hospital, that's where I was working, and then there was another one down in Eastern Cape. So those were the ones that were reaching the targets. And the success was really around kind of all of those sites that rolled out to primary healthcare clinics. At the sites where it remained centralized at hospitals, they did not manage to reach the targets. There was also quite a concerted effort around managing HR and various systems. So particularly integrating systems and linkages, the thing about the ARV rollout as a leverage. So we used ARV, kind of the reason for, kind of the requirement of having regular kind of blood tests in clinics improved the access of laboratory altogether to primary healthcare clinics. It's that kind of idea. So, and similarly with the supply services. And there was quite a lot of innovation and kind of inside the system, so kind of really finding innovative ways around different complicated rules next to the system, so setting up parallel things that would kind of manage it. So quite a lot of ARV sites had their own data management system because the main data management system in the Department of Health wasn't functioning terribly well. And then outside of the system, and often that was against policy. So I can talk a little bit about a good friend of ours, Colin Pfaff, who had a very interesting experience around that. So I've mentioned I've mentioned the data already and the linkages with the NGOs. Okay. So there's something really transgressional about this if you want to run a good service. But I think the really key issue in all of those sites that there were positive people in the face of the pandemic. So I think that without that, it couldn't have happened. Just an example of that, these are the reason I've got access to the slides. This is the site where I was working at in Emmaus Hospital. It's in the rural KwaZulu-Natal. I think Neil came to visit us there once. And this is really the time from when we started ARVs. And the bars indicate how many patients were initiated on ARVs per week. So this is every week, the initiations. And so in the beginning, as we were setting up, it was quite chaotic. We weren't getting anywhere. Then we started to get going. It was a little bit more regular. But we started to become quite congested. These two bars here, that missing tooth, that is Christmas, so nobody was initiated over Christmas. But then we started to get quite congested, and we really couldn't cope with additional people being initiated until we referred to PHC clinic. And that down referral was basically people were initiated on the ARVs, they were followed up for about 6 months. If they were stable, they could then be followed up in primary care clinics, and every 6 months needed to come back to the hospital. So that was the down referral system. But that red line was the target that we were trying to reach in 2011. And the moment we rolled out to the primary healthcare clinic, we exceeded that target. The reason we then started to fall down again, that after the slide, if you carry on the timeline, goes up again, is because there weren't enough people testing for HIV at the time. So the VCT, access to VCT, then became the major limitation on getting onto the ARV program. Okay. So kind of this really, kind of for us, has been a story around the rural as being a site of innovation, like that there are lots of people really innovating and finding good solutions to big problems in rural areas. And critical within that is that we were quite close to the context, so you could really deal with real issues as they were, and it wasn't some theorized, distant process. The second thing is that you were outside of the gaze, and I don't know how familiar you are with the Foucauldian gaze, that is a very controlling gaze, so the bureaucracy controls by seeing you in various ways. So if you're not seen, if you can fly under the radar, you can do all sorts of things.
Until you get seen.
Until you get seen. So outside of the gaze of the bureaucracy, outside of the gaze of politicians, that in South Africa was something really important. And then, but also to some degree outside of the gaze of academics, that kind of you can really innovate if it's not part of a research project. But then a lot of people also use the gaze or being seen as leverage. So having a connection with politicians, kind of getting a sign-off for the project that you're running, like having some influence in the bureaucracy, but also kind of quite a lot of very innovative ARV programs, particularly in Church of Scotland and a few others, were as a result of collaborations with academics. So I think that one needs to balance those two things. And I think generally, as I said in the beginning, anything is a miracle. And so we got really high returns if your expectations are quite low. So I think that's quite important. But critical with this is that a lot of this has remained completely undocumented. We were far too busy doing things and then to really start to look at what was actually going on. And I think that's, for us in rural health, has increasingly become an issue that it's not only about documenting, but also learning as we are busy doing. And I'd like to hand over to Mosa to kind of start to talk a little bit more about the evidence that is starting to be built around this.
Thank you. So there's been a few areas in South Africa that have been successful in documenting and generating evidence around HIV care in rural areas. In most cases, as Bernard said, there's a lot of work that has been done, but we don't necessarily have data or research or evidence around it. The one thing that is common about the sites that have been able to produce data is that they already have research centers in them. So the Africa Centre that some of you may know about is a demographic surveillance site. And in Bushbuck Ridge, where there is also a demographic surveillance site, although the DSS site itself was not involved actively in the HIV research, those of us who were in the vicinity, we were able to do research around these issues. But there's something about being in close proximity to people who do research when you're in rural areas that you naturally begin to actually attach value to generating data. And a lot of the work that we did at the time, it's things that we did after hours. You go to the clinic, you see patients, and then after hours you start analyzing data, etc. Until you decide that you want to do it on a more sort of full-time basis. Okay, let me tell you about this conceptual framework. Right? This conceptual framework basically talks about the struggle we were having at the time of the rollout in around 2006. And the issue was we were sitting right up there in the ART clinic. And all we could see is people who come to us, and then these are the outcomes. Some of them would die, some of them would get better, and all of the things that happen in between. But we kept asking ourselves a lot of questions because, policy, whether we like it or not, policy is influenced by people who are in power, and if you are at the bottom of the food chain, you want to generate evidence to be able to earn your place to speak and begin to influence policy. And we were not able to influence policy regardless of the problems that we were facing on the ground. So, for example, we were trained within a Western medicine, but then there was a whole lot of things that we experienced that patients brought into healthcare that had to do with religion, that had to do with their livelihoods, that had to do with traditional beliefs and practices that were not necessarily accounted for by the guidelines, antiretroviral treatment guidelines that we were following. And so this was a problem for us, and we then decided that, okay, we need to actually generate evidence relevant to us. And that is the problem, because people assume if you've got evidence coming out of South Africa, it applies to South Africa. And yet in South Africa you have such diversity. And we were not necessarily taking into account particular issues that affect the local context. And so we had to then learn how to do that. And for us, this actually represents what we're trying to do in rural health, because it's not easy for us to generalize information. Even when we see good research data and output, we still look at it with a skeptical eye, because does this actually apply to my context? So, in the ARV program, and this is a slide that is coming from the Africa Centre, and you will hear me talk about Bushbuck Ridge and the Africa Centre a lot just because of what I've already told you. Within that community, that geographic catchment area, what they would do is, during the surveillance studies that they do, they would test anonymously for HIV. But they are also, in the population, they do household surveys anyway. But they're also able to link the data to people who go to their ART clinic within their demographic surveillance site. And so they're able to produce a slide like this, where they will tell you, okay, amongst all the people that we found to be positive in the population, this is the proportion that is actually linked to care, and it's roughly 50%. But then, along the cascade of care, there's also a number of dropouts, such that people who are successfully in treatment are at that level. And we are busy working with them to try and refine this, to develop this cascade. But it's become really important that when we work in those geographically demarcated areas where you've got a defined population, you are able to account for all the people who need care and people who are accessing care. A lot of the data that we have in HIV and ART is based on people who actually access care. We don't have a lot of information on people who need care but don't access it. And it's got to do a lot with the stigma around HIV and the policies that we have that make it very difficult for us to work with those people. But also, you know, there's a lot of structural issues that affect that process. But the data, again, coming from the Africa Centre, it showed that, you know, at the initial stages of the ARV rollout, so from 2003 to 2007, in this rural community, the incidence of HIV was at that level, edging on a slight increase over time. And the ARV rollout started in 2004 in this community. We now know that the antiretroviral treatment has made a lot of impact because if you look at the incidence of HIV where people have good coverage of ART, if the coverage of ART increases, the incidence tend to come down. And we've seen this also in global data. There was, a few years ago, there was data from I think somewhere in Europe, I think it's the Swiss or somebody, but they were arguing that HIV becomes protective. And I mean, people were talking about herd immunity, etc., etc. And this was the idea that the more we put people on treatment, the better we are at in terms of reducing the drug viral load and therefore reducing their chances of transmission. But there is still a lot of questions around these issues that need to be unpacked. The other thing that we saw was that when we put people on antiretroviral treatment, a lot of them died initially. And we were starting people at very late stages of their AIDS course of illness. And what was really sad, and this basically shows you the attrition rates of people that we looked at in Bushbuckridge. What was really sad was that a lot of people died even in hospital despite access to treatment. And many of the people who died, we later found out when we looked closely at the causes of death, was that nearly 50% were dying from TB. And another 25% were dying from diarrhea. And all of them we considered preventable deaths, so to say, because then there's treatment. If you looked at the data from the urban settings, you realize that the proportion of people who were dying, that was smaller. And when you looked at the specific causes, it was Kaposi sarcoma, and you would also find people dying from immune reconstitution due to other infections that they were not able to treat at that stage, just after they started ARVs. But all in all, we found that the retention within the ART programs was comparable to other sites. So for example, after 2 years, you will still find about 85% of people remain in care. But at the early stages of the ARV rollout, we had a lot of losses in terms of deaths. And this was also related to the debate that we were having around adherence. Initially, people argued that adherence in rural areas is going to be poor, but that was not the case. It was actually quite high. We also realized that now we know that over time, even life expectancy has now increased. And this is also from a rural setting in the northern KwaZulu-Natal. And northern KwaZulu-Natal is particularly interesting, as you've seen from Bernard's slide, because we've got quite a decentralized healthcare system. So coverage of ART access is quite high. And so life expectancy has come up. In 2004, this is when the rollout started of ART. But this slide from our colleagues at the Africa Centre shows evidence of that. Socioeconomically as well, we are now beginning to see that once people have been started on ART, more and more people are coming back into the active socioeconomic lifestyles. They're beginning to go back into their jobs, and it's coming closer to what it was at the baseline. There was no statistically a significant difference here. And this is also a slide from our colleagues at the Africa Centre, Till Banninghausen. And we are very pleased to see this because a lot of the people that were initially affected by HIV/AIDS in rural areas were the socioeconomically active age groups. And there's a lot of people who are migrants living in these rural areas who go into the urban cities. And when they got sick in the urban settings, they came back home. And there's a lot of literature written around people coming home to die just because they got infected in the urban settings but then came back. And a lot of the people, women in rural areas, people were arguing that a lot of the infections they have are from their migrant partners who live in the urban areas. So the whole issue of migrancy, etc., played an important role in HIV, as did travel influence HIV transmission all over the world. Now, I just want to speak to this because there was a lot of debates around concurrency in general. We started talking about multiple concurrent partners. And theories were suggesting that the spread of HIV/AIDS in sub-Saharan Africa, for it to be so bad, is because of multiple concurrent partners. Which people were arguing that it's different from what you see in developed countries where you may have, even though you have multiple partners, it can be serial monogamy. So our colleagues at the Africa Centre, Frank Tenser, they did this study, and they are trying to respond to a review that was put out by Still Wegon and colleague that argued that MCP, if you look at the evidence around multiple concurrent partners, it's questionable. Now, just in terms of this, they found that multiple concurrent partners, there was no statistically significant difference among people who were, with regards to HIV incidence. It was the same regardless of what quartile you were in, what the number of partners you may have. But when they looked at a total number of life partners, they saw this nice trend. And their argument, their conclusion was that it was not so much the concurrence, it was more the issue of the total life partners. The more partners you have over time, regardless of serial or concurrency, you will have increased HIV incidence. And this paper is quite interesting. I think it's in Science or The Lancet. It's quite interesting if you read the whole book because it looks at this question from different angles and it comes to the same conclusion. When Melissa was introducing us, she mentioned the issue of plural healthcare systems. And I would make a big mistake if I don't talk specifically to this issue. And if you look at the literature around plural healthcare systems, a lot of the times people look at it in terms of the traditional healthcare system in the West, which is the formal healthcare system in our context. And they also look at alternative forms of healthcare or complementary forms of healthcare. So you've got complementary and alternative medicine. Now, a lot of the times people talk about formal and private healthcare systems when we look at the health systems. And when we did this study, which we already knew this, especially in rural areas, but we were able to demonstrate it here, that people move between systems. And when you try to categorize those systems, they range from self-care to formal healthcare clinics that we consider the healthcare system, even in South Africa, between the public system and the private system. But they also go into the private shops like chemists and over-the-counter, etc. And they also go and visit prophets. And there's a lot of people who go to their churches, etc., for healthcare. And that is not necessarily formally recognized as a source of healthcare. And there's a number of people who also go to traditional healers, etc. Now, this is an example of one person whose journey it was to try and get to accessing ART. Although at this time ART was not available, one is able to see that this person refused to be tested in 2003, and we generated similar models for about 32 other people in a longitudinal qualitative study to try and understand what healthcare systems people in rural areas use. And after refusing VCT, they went to traditional healer, and they were told that they'd been bewitched. And for someone who doesn't work, $50 in 2004 was a lot of money. But that's what they paid for the prophet. That's what they paid the chemists. And we're increasingly beginning to appreciate the role of the ability to pay, ability to afford healthcare, even in rural areas. The scale may be lower, but the impact is quite high. And eventually this person was able to be tested in 2004 and received ART. And once again, we also realized that in all our participants, there was huge delays from the point of symptoms. And oftentimes these were symptoms already relating to the AIDS stage, to the point of HIV tests. But the delays were also between the test and the actual ART initiation. And people have written a lot about this, but this sort of pictorial demonstration here, it just shows the journey people travel through the health system. We looked at it in a different way, where we took all our participants and we looked at where they started when they started to consult, and to see whether they stay in that system. And most people start off in the public sector, in the primary healthcare clinics. And but over time, people switch between systems. They go public, private, they go formal systems, and they go in between like that. And if you then have to look at your healthcare system and try to define it, it's not enough to actually be looking at the public health system as a representative of the health system. And also, adding only the private health system is not enough, because people go to the less formal kind of healthcare systems as well. So if you have to plan from a policy point of view, the health system needs to be broader. But that is not the case. And this is more pronounced in the rural healthcare system. We compared people who access treatment in rural areas to those who are in urban areas in terms of the types of health systems that they go to. And you can see for the private doctor, and you can see in the private chemist, that there's a lot of people who use that in general, both in urban and in rural areas. But here, more people in rural areas tend to use traditional health systems. Also, people tend to use traditional health systems more often in rural, the private doctor more often in rural areas, but the chemist is used a lot more in urban areas. And this may be a reflection of access, because in rural areas people are able to go to the private doctors, and they don't have a lot of private chemists, and people in rural areas don't necessarily see chemists as a source of healthcare. But the people in urban areas are a little bit more empowered to decide on their own what they want to buy for themselves. And once again, the primary healthcare system and the public health hospitals were used a lot more. In rural areas, you can see that the proportion used into PAC is higher compared to people going to the public hospital when you compare urban and rural. In terms of costs, people pay more money for going to traditional healers. And you can see that they pay up to over $100 US dollars to see a traditional healer. They also pay a lot of money for the GP, but there's a lot of money that's paid on people looking after themselves. The primary health care costs almost nothing for people who go there, except in a lot of cases, ARVs initially were not accessible there. They had to actually go to the hospitals. And in places where they were able to decentralize ARVs to primary health care, it made it a lot more accessible for people. The other things that we noticed when we looked at factors that are associated with this behavior of plural healthcare utilization was that it was driven a lot by quality of healthcare issues. For example, lack of privacy and disrespect by staff. And it's quite interesting how much people in rural areas value respect. And when we compared it to the urban data, it was much more valued in rural areas than in urban areas. Now, what we find interesting is that if you are, if the same person who is in a rural area and who values respect, if that same person goes to an urban area, they are able to adopt ways of living in the urban lifestyle, and they would not mind if people don't greet them. But if they are in their rural context, being greeted is a lot more important. And so this is also a reflection of structural things that you see between urban and rural. As I've already indicated, people who were using multiple healthcare systems suffered a lot of catastrophic expenditure. I mean, they used a lot more of their household earnings on healthcare. And in this case, catastrophic was 15% of the total household expenditure. A lot of it went into healthcare. And of course, some of the consequences were that they had to borrow money because they could no longer be able to finance their healthcare. Excuse me for this slide, but what I just want to point out on this slide is that these are two rural districts that we looked at. Bushbuck region, Hlabisa is where the Africa Centre is, compared to two peri-urban settings. And you can see in general, people spend a lot of money in rural areas paying for healthcare compared to peri-urban areas. This was very interesting because in Hlabisa, a lot of money was spent on transport, etc. But Hlabisa also had a decentralized healthcare system, which was more decentralized compared to Bushbuck Ridge. But they spent a lot of money on transport. You're also able to see the travel time in the rural districts was much higher compared to urban and peri-urban settings. So these were some of the variables around access to healthcare that we have looked at, specifically for ART. Now, when we decentralized the ART system in Bushbuck Ridge, people who were taking medicines in the hospital were shifted to the primary healthcare setting. And we looked at a number of variables that affected that. And on the whole, we realized that their experience of access to healthcare improved when they started taking medicines in their local clinic, because they gained in terms of time of travel, it was reduced. In terms of the money they paid for transport, it was reduced. We initially thought that people would experience a lot more stigma, perception of stigma in their local communities, but those results were not significant. And that was a surprise finding for us. We also looked at the total healthcare. The healthcare system was defined in broad terms in this case, and we found that although the people who were down referred to their clinics had an experience of improved access for ART in the public health system, their consultations with private doctors increased, and their use of self-care medication medicines increased, and their expenditure in total around healthcare increased compared to people who were still going to the hospital. So for us, it meant that there were gains in down referral, but there were also losses. And where we think that the primary healthcare setting was not able to meet their needs, they compensated by going to GPs and buying things themselves. And when we looked at their total expenditure, it was not necessarily to their benefit. And so this was a problem because we are doing it with the good intention of improving access, to bringing it closer to them, but there is this hidden harm that is taking place. I just wanted to, before we finish, I've got 2 more slides. I just want to talk about the role of the non-profit organizations. A lot of the times, when we look at the healthcare system, we tend to talk about traditional healers, private doctors, etc., and we don't talk much about non-profit. And Bernard reflected on this, that when it comes to the ARV rollout, the civil society and the NGOs played a key role in improving access to healthcare. And if all of the factors that played a significant role in improving access to health to ART in South Africa, we believe that those all of those players would play an important role in strengthening the health system and should be considered as part of the health system. Because if it was not for the role that they played, we would not have been able to hit the targets that we have so far. Yes, we have the largest antiretroviral rollout in the world, but we can't necessarily boast about it because our incidence is still high. The recent report that came out last week from HSRC still suggests that 400,000 people are still getting new infections in 2012. And the total number of people that live with HIV is now 6.4 million, estimated. But at the moment, there is a lot of debate around non-profit organizations, a lot of policy debates around it in terms of what should be done with them. And it's community health workers who work under these NPOs at a community level. And these community health workers, there's a debate as to whether to incorporate them into the HR of the government to become civil employees, or to leave them under the NPOs. And it's not an easy decision. But what we found in a study that we did, it was published in Health Policy and Planning, is that NGOs are not only providing service, they also play an important role in terms of activism and development. And when we compared NGOs in the urban areas and those in the rural areas, we found that the ones in the urban areas have a stronger role to play in activism and development compared to rural areas. In rural areas, they play more of home-based care roles. But also, it was clear that NPOs that have better resources, like these ones, they play more of the activism and development role. But the ones that have less resources tend to play more of the service role. We looked also in terms of, we constructed a historical view of the NPOs that existed in Bushbuckridge between 2010 and 2013 to see how long have they been in existence. And we realized that many of them are quite recent and centered around the increasing epidemic of HIV. So the NPOs and a lot of the community health work that happened was influenced a lot by the need for HIV services. We thought that once the ART rollout grows and the expansion carries on, the need for community health workers and NPOs will reduce, but current data suggests that actually there's still more NPOs that are being formed at community level, especially in rural areas. So this area is still an area that's still open in terms of research and to look at. There was another slide that I had in there, but unfortunately I had to take down because I know I can talk all day. But that slide was talking about children who are looking after parents or their caregivers. So in a household, you have a child who looks after a sick parent or a sick caregiver. A lot of data is coming out of that piece of research, and one of them suggests that they are at an increased risk of TB. If you compare children who are looking after parents who, using the verbal autopsy data, we are able to see that they may have had TB. or parents, children who are looking after parents who have other chronic conditions, not HIV, TB, but perhaps hypertension or diabetes. The children that are looking after these parents with infectious diseases are also exposed, and the risk for acquiring those infections is quite high. And unfortunately, those children don't necessarily have access to health care. And diagnosing TB in a child is very hard, and in rural areas it can be even harder. So that is another question that we're looking at, and we are realizing that there are a whole lot of sources of health care and healthcare services that are taking place in the household and in the community, but are not necessarily seen as part of the health system. So I'm gonna stop there, and all of us are gonna address questions or comments or anything else that you want to raise.